Here I have a prepared skull. I will be reviewing the bony anatomy of the skull as it relates to the nose and paranasal sinuses. These relationships are very important both for endoscopy and a general understanding of the pathology and pathophysiology of these structures. Before disassembling the skull, I'd like to review the relevant superficial anatomic landmarks. In this skull, we see the typical frontal bossing, which is caused by the frontal sinuses. This individual probably had a broken nose, and the small nasal bones are deviated to the patient's right. You will notice that the cartilage and other soft tissues which comprise the majority of the external nose are absent. The frontal sinuses, the ethmoid sinuses, and the maxillary sinuses comprise three walls of the orbit. The bony partitions which separate the sinuses from the orbit are very thin. We'll be showing you a transillumination in a few moments. If we look through the bony opening in the skull, which is called the piriform aperture because it is pear-shaped, we see several things. We see the bony remnant of the septum. And again, because the nose is deviated in this individual, it is deviated to the patient's right. We can see through to the inferior concha, which is the bony structure of the inferior turbinate. Now the floor of the nose passes directly backward over the hard palate, which is part of the maxilla. And the ridge, which receives the septum, creates a small T anteriorly. If we look deeper into the nose, we can see the middle turbinate. You will notice also on the lateral view that the molar teeth have roots which extend up into the floor of the maxillary sinus. We've dimmed the lights now, and I'd like to demonstrate the relationship of the frontal sinus to the orbit by transilluminating it with a fiber optic light source. Here we can see the sinus light up, very clearly demonstrating that the frontal sinus is juxtaposed both to the brain and the contents of the orbit. Here I've repositioned the fiber optic light source on the medial wall of the nasal passage. When we come in a little more tightly, we can actually see what appears to be foamy bone comprising these very delicate ethmoid air cells along the medial wall of the orbit. Typically we see 3 to as many as a dozen on each side. The thin bony partition separating the sinuses from the orbit is called the lamina papyracea, which means paper thin. I've placed the fiber optic light source against the hard palate. The bone beneath the maxillary sinus is so thin that the light passes into the maxillary sinus, out the thin anterior maxillary wall, out the thin wall into the nasal passage, and into the orbit through the thin floor of the orbit. You can see how thin the floor of the nose is, and that the floor of the nose is the hard palate. We can also see out the posterior choana around the inferior and middle turbinates into the area of the nasopharynx. The last relationship I'd like to review before we disassemble the skull is the relationship of the nasolacrimal duct to the inferior meatus. Now, the tear duct drains into the lacrimal sac, which sits in this little fossa. Now, there are ethmoid cells immediately below this depression. The medial canthal tendon which holds the inner corner of the eyelids, attaches on both sides of these crests. Now if I pass a probe into this duct, I'd like to demonstrate for you the appearance here from above, and also intranasally you can actually see this probe. Can we come in a little tighter? You can see this probe as it comes into the anterior roof of the inferior meatus. Now this is the only orifice that opens into the inferior meatus. When you pass a fiber optic endoscope into the inferior meatus, you usually cannot see this opening because it is in the roof and you can't angle the scope acutely enough. I'd like to now disassemble the skull and review some of the internal relationships that are important. Now to demonstrate the internal anatomy, this prepared skull had a calvarium which could be removed above, a left side which was removed, and this right side that we have is a parasagittal section, so the septum is still present, and I've removed the jaw from below. We can now turn our attention to the internal structures. Superiorly here we see the right frontal sinus that we had transilluminated earlier. There is an outer lamina and an inner lamina, and this is really an anterior ethmoid sinus, and its duct extends down into the middle meatus, and we'll be reviewing that in a moment. We see the nasal bones. We see the various septal bones. The quadrangular cartilage, which was in this area, is absent. But you'll notice that it comes to a point, a wedge. It sits in a groove in the maxillary crest, and the crest that receives the septum anteriorly has a maxillary crest and posteriorly has a palatine crest. There is a wedge-shaped bone posteriorly here, which is the vomer, and the vomer creates the majority of the partition of the posterior choana. The very thin perpendicular plate of the ethmoid extends up to the cribriform plate where the sense of smell originates. Posteriorly we see the sphenoid sinus. And you'll notice that the nasal vault anteriorly is much higher than the posterior nasal vault, where this opening comes into the nasopharynx. Now the distance from the nares anteriorly to the posterior choana here is about 2.5 to 3 inches, and all the way into the nasopharynx is about 4 inches. You will notice again that the hard palate and the floor of the nose are one and the same structure, and that if you were to pass an endoscope or some other tube into the nose, you would ideally want to pass this straight back. If you're passing this upward, you're going to be impinging on the cribriform area. I've set the right side of the skull, which contains the septum, aside, and brought out the left side of the skull, which does not have a septum. This view will demonstrate the features of the lateral nasal wall. Now again, this is the left side, and the septum is removed. We're looking through to the left lateral nasal wall. You'll recognize above the frontal sinuses. Here we see the right sphenoid sinus and the intersinus septum. We're not actually looking into the left sphenoid sinus. The asymmetry of sinuses is really the rule rather than the exception. You will notice the hard palate inferiorly and how thin it is. Here we have the cribriform plate. It's perforated where all these little nerves pass into the cribriform area of the nasal passage. We see the superior and middle turbinates, which are part of the ethmoid bone. We see the inferior turbinate, which is a separate bone. It is the inferior concha, which fills a window in the maxilla laterally. Now, as I had demonstrated previously, the only structure which opens into the inferior meatus is the nasolacrimal duct. The middle meatus, on the other hand, is a very busy area. We see the nasofrontal duct, which I'm going to try to cannulate here. Here we go. Passing into the anterior end of the middle meatus. In the mid portion, we have the maxillary sinus opening, and then by definition, the anterior ethmoids open into the middle meatus. Now, it is difficult to see in this specimen the hiatus semilunaris, which is a semilunar valley of sorts. The bulla ethmoidalis, which is the postero-superior rim of this valley, is where the majority of the anterior ethmoid air cells reside. The nasofrontal duct often opens at either the anterior end or as a separate opening from the semilunar hiatus. You will notice posteriorly the choana. And again, when you look at the choana from the anterior perspective, you will see the face of the sphenoid and the large sphenoid ostium up here in the sphenoethmoid recess. Now, this small superior turbinate defines the superior meatus, and the posterior ethmoid air cells enter into this cleft, and that's adjacent to the ostium of the sphenoid. The other group of sinuses really comprise the middle ear, and they open into the nasopharynx. Here we're looking at the left frontal sinus, and again we can see the outer lamina and the inner lamina, sometimes called the anterior and posterior lamina of the frontal sinus, and the nasofrontal duct. You'll notice that internally there are septi, and this is normal. Often we have a supraorbital extension where this forms a tract of air which extends over the orbit. The extent of this sinus is extremely variable. A significant number of individuals do not have a frontal sinus. This individual has a typical or average sinus. Some individuals have frontal sinuses which are so large that they extend back almost to the temporal bone. You can see that infection here can readily spread through small veins which perforate this posterior lamina into the dura and brain. You can also see that infection here could extend inferiorly into the orbit or anteriorly into the bone and periosteum. When the infection spreads anteriorly, we call this a Pott's puffy tumor. Here I've gone back to the right side of the skull to demonstrate some features of the sphenoid sinus. You'll notice that this sinus is fairly centrally placed in the skull, therefore pain is often felt behind the eyes or in the temples or even in the occiput. You see the sella turcica, where the pituitary resides. Other structures that are immediately adjacent include the carotid artery, the internal carotid artery, the optic nerve passing through here. Although the sphenoid sinus is very close to a lot of very important structures, it is relatively protected from infection because of its very large, short ostium. Here we're looking from the sinus side out through the ostium. This ostium is only 1 millimeter long and it's about 1/4 of an inch in diameter. I've partially reassembled the skull so that we can examine the bony anatomical landmarks of the nasopharynx. I'm going to rotate the skull to where you're looking from behind and tilt it forward. Now, when you see the skull from here, can we come in a little bit tighter? When we see the skull from this perspective, you will notice that the roof of the nasopharynx is the sphenoid sinus. The structure which separates the nasal passage on the right from the left is the vomer. These are palatine bones inferiorly. Now out here we have the pterygoid plates, which is where muscles of mastication attach. And you can see the thin, hard palate, and you can see the inferior and middle turbinates from behind. Now I'm going to tilt this up slightly, and I'm going to be cannulating the eustachian tube orifices. One of the prominent structures of the nasopharynx is the torus of the eustachian tube. I've taken a flexible wire guide, passed it through the nasal passage, through the eustachian tube orifice, and out the external auditory canal. Here's a closer view of these relationships, and you can see the wire guide passing through the bony eustachian tube orifice. We're looking at the skull from inferiorly. This is the foramen magnum down here. This is the clivus. This is the vomer and the posterior choana. And you can see that the wire guide is coming through the nasal passage. It would enter the soft tissues, which comprise the torus tubarius here, and we've got a fairly long cartilaginous eustachian tube and a fairly short bony eustachian tube. The larger openings posteriorly here are where the carotid artery and the internal jugular vein pass up immediately medial to this bony eustachian tube. Understanding these bony anatomic relationships gives us greater insight to interpreting both normal variations and pathology found on endoscopy.